So let's look at the pathophysiology of pelvic inflammatory disease. There's infection of the upper female genital tract, which leads to inflammatory changes resulting in scarring, adhesions, and partial or total obstruction of the fallopian tubes. This can result in the loss of ciliated epithelial cells along the fallopian tube lining, resulting in impaired ovum transport and increased risk for infertility and ectopic pregnancy. Additionally, adhesions can lead to chronic pelvic pain. The microorganisms that are implicated in PID are thought to spread in three ways. The spread can be intra-abdominal, traveling from the cervix to the endometrium through the salpinx and into the peritoneal cavity. There can be a lymphatic spread, and there can be a hematogenous spread, such as which happens in tuberculosis, which is although a rare disease in the developed world, but we still see tuberculosis of the genital tract in the third world. Next, please. So this is just to explain the pathophysiology. You can just see that the microorganisms from the lower genital tract can ascend into the endometrium, fallopian tubes, into the peritoneum. And the sexually transmitted organisms like Neisseria and Chlamydia have been isolated from the cervix, endometrium, and fallopian tubes of women with histologically confirmed endometritis and usually confirmed salpingitis. They are universally accepted as etiological agents of PID. So these two, Chlamydia and Neisseria, are globally the most important and the most common organisms implicated in pelvic inflammatory disease. Next, please. So there are certain risk factors in relation to the sexual behavior of an individual, which puts them at an increased risk to develop PID, such as young age, less than 25 years of age, multiple sex partners, a recent new partner, that is in the last 3 months, past history of sexually transmitted infections in the patient or their partners, instrumentation of the uterus, interruption of the cervical barrier. Various procedures also put the patient at an increased risk of developing PID, such as termination of pregnancy, insertion of intrauterine devices in the last 6 weeks, hysterosalpingogram, hysteroscopy, saline infusion sonography, and in vitro fertilization. So these are the procedures which actually put them at an increased risk of acquiring pelvic inflammatory disease. Next. So how would a patient present once there is an inflammation of the genital tract? The most common symptoms would be a lower abdominal pain, which is usually a bilateral pain. There can be some abnormal, unpleasant cervical discharge, which is often plurulent. It could be deep dyspareunia, abnormal vaginal bleeding, including postcoital bleeding, which is very, very important and one of the significant symptoms. There can be intermenstrual bleeding, heavy menstrual flow, and secondary dysmenorrhea. Next. On clinical examination, the signs could be lower abdominal tenderness. Bimanual pelvic examination can elicit adnexal tenderness, cervical motion tenderness, and of course, fever, which is mostly an important clinical sign, anything more than 38 degrees Celsius, which is a common presentation in moderate to severe disease. Next. So this is just to show that a large proportion of women who have pelvic inflammatory disease may not show any symptoms. So this diagram shows you that about 60% of PID patients would be actually subclinical. They may not have any of the classical symptoms and signs of PID. And about 30% are going to have overt PID that can be mild to moderate. And in about 4% of patients, it can present as a severe disease. So it's very important to suspect this condition, as we can see that a large majority of patients can be either asymptomatic or they can have non-classical presentation of PID. Next, please. Now, looking at the various symptoms and their prevalence, if you look at the various symptoms and their prevalence, in terms of symptoms, the most prevalent symptoms would be having irregular vaginal bleeding. And this is usually a concerning symptom in young women of reproductive age. There may be many other reasons to have irregular bleeding, but PID is one of the common underlying cause of having irregular vaginal bleeding. And this can be followed by any kind of unpleasant vaginal discharge, which would be usually a mucopurulent cervical discharge. In terms of various symptoms, we said that bleeding and discharge are the leading symptoms. If you look at the signs, then fever in mild, it's not a feature in mild disease, but in moderate to severe disease, there's often a history of fever, and the lab investigations will show a high white cell count and a high ESR. These would be the lab findings in women suspected to have pelvic inflammatory disease. Next, please. So how would you diagnose? As we said that a large number of women may not be symptomatic, so PID can therefore be symptomatic or asymptomatic. The positive predictive value of a clinical diagnosis is 65 to 90%. So that means it is not that whenever we suspect PID, it may be a PID. There may be many other reasons to have clinical manifestations of PID. Testing for gonorrhea, chlamydia, and mycoplasma genitalium in the lower genital tract is recommended since a positive result supports the diagnosis of PID. So whenever we have a suspicion that a woman may have PID, we go for different swabs. And now the current guidelines show that instead of taking the high vaginal swabs, we take the vulvovaginal swabs. And for Neisseria and chlamydia, as well as mycoplasma genitalium, we do the NAT test, which is highly sensitive for these organisms, and these can be self-taken by the woman. It is not necessary for a healthcare professional to take these swabs. They can just be self-taken and brought to the health facility for testing. Next. Now, in terms of the blood test, as I said, an elevated ESR or C-reactive protein or a high blood white cell count supports the diagnosis. The absence of endocervical or vaginal pus cells on gram stain examination of a vaginal smear has a good negative predictive value, which is 95%. That means if you do an endocervical swab and you do not see any pus cells, or you do a gram staining of a vaginal smear, it has a high negative predictive value. That means it's unlikely that the woman is going to have PID. Next. Now, other investigations that can be done to support or make a diagnosis of PID, the first line usually done is a pelvic ultrasound, usually a transvaginal scan. Ultrasound scanning does have a limited value for uncomplicated PID, but is helpful if an abscess or hydrosalpinx is suspected. MRI or CT scan of the pelvis may be helpful in differentiating PID from alternative diagnosis, but are not indicated routinely. So usually the first line imaging test that is done in a suspected patient would be a pelvic ultrasound, and this would be useful when there is moderate to severe disease, such as the image which is showing a hydrosalpinx, which is present in this image. However, if it's an advanced disease where the patient presents with swinging high temperatures, severe pain, and mucopurulent discharge, and is otherwise unwell with raised ESR and white cell count levels, then probably a CT scan or an MRI would be more useful. Next. Now, these are the MRI images, and it shows bilateral hydrosalpinx, which is very, very clear. You can see the arrows are pointing towards the hydrosalpinx. And these are very clear pictures which can confirm the diagnosis of PID. Next. Now, in any woman of a reproductive age, especially when she presents with lower abdominal pain and some kind of an unpleasant discharge, the first thing that we need to do, the first test that we need to do is a pregnancy test. A urine pregnancy test is very important because top on the list would be an ectopic pregnancy. Other differentials that are important in gynecological conditions would be, of course, going for a PID, endometritis, ovarian cyst accidents such as torsion or rupture of the cyst, and non-gynecological would be an acute appendicitis, irritable bowel disease, diverticular disease, or sometimes it may be an underlying psychological condition, what we call as pain of unknown etiology. However, top on the list would be an ectopic pregnancy, which should always be excluded in any woman who's in the reproductive years, irrespective of her menstrual history. She may not have actually missed her period because an ectopic pregnancy can have multiple presentations. So the first simplest investigation that should be offered for would be a urine for pregnancy test. And if it turns out to be positive, the next thing that needs to be done is a transvaginal ultrasound to have a clear look and to make a diagnosis or exclude the diagnosis of an ectopic pregnancy. And then you can have the ovarian cyst accidents, endometritis, that's important differential. Urinary tract infections are also common in women, and these should also be excluded in the differential diagnosis. Next. So how would you manage a patient presenting with a suspicion of pelvic inflammatory disease? Now, it's very important to understand that delaying treatment will increase the risk of long-term sequelae, such as ectopic pregnancy, infertility, and pelvic pain. So if you look at the overall clinical scenario of pelvic inflammatory disease, there are no definitive diagnostic tests for this condition. However, there has to be a high degree of clinical suspicion to diagnose PID. Therefore, if there is a clinical suspicion, treatment should always be started as early as possible, because if it is not done, it can lead to serious damages in terms of fertility, in terms of quality of life, leading to chronic pelvic pain, ectopic pregnancy, and fertility. Because of this and the lack of definitive diagnostic criteria, there should be a low threshold for empirical treatment of PID, which should be recommended and should be started as early as the patient is suspected of having this condition. Next. Now, there has to be some general principles. The general advice is rest is advised for those women who have serious disease, and they may actually be admitted to the hospital. They need appropriate analgesia. For those who are admitted inpatient, they are going to be put on intravenous treatment. It will be recommended for patients with more severe clinical disease, like having high-grade fever, clinical signs of tuber-ovarian abscess, signs of pelvic peritonitis, and of course, general advice regarding safe sexual practices until the woman and her partner have been completely treated. Next. So let's come back to the subject. We said that in the management, there's going to be some general advice in terms of hospital admission for those who present with severe disease, to give them rest and appropriate analgesia, followed by intravenous antibiotic treatment. And of course, they must be given safe sexual practice advice. Next, please. Now, in terms of those patients who present with mild disease, they can be managed in the outpatient. And the outpatient therapy is as effective as inpatient treatment for patients with clinically mild to moderate disease. Those patients who have severe disease will be admitted for parenteral therapy, observation, further investigations, and for possible surgical intervention. And this can be considered in emergency situations. A surgical emergency cannot be excluded when there's a lack of response to oral treatment, and when there's a clinically severe disease or suspicion of tuber-ovarian abscess, intolerance to oral therapy, or in a woman who has inflammation and she's pregnant. So in these conditions, the patients are admitted for further management, observation, and treatment. Next, please.
Alhamdulillah.
So what are the outpatient regimes? The recommended regimes by the RCOG and by the CDC are that the outpatient regimes are first-line treatment is injection ceftriaxone 1 gram intramuscular as a single dose, followed by oral doxycycline 100 milligrams BD plus metronidazole 400 milligrams BD for 14 days. And the second line would be oral ofloxacin 400 milligrams BD plus oral metronidazole BD for 14 days. So it's important that whenever you have a diagnosis of PID, the antibiotic has to be completed for 2 weeks' time, The treatment is 14 days. Next. Now, for the inpatient regimes, those who are admitted for intravenous antibiotic treatment, intravenous ceftriaxone 2 grams daily plus intravenous doxycycline 100 milligrams BD, followed by oral doxycycline can be used if tolerated. And this oral doxycycline will then be combined with metronidazole to complete a treatment for 14 days. So initially it is ceftriaxone and doxycycline, followed by oral doxycycline and oral metronidazole, completing the treatment for 14 days. Next. Now, clindamycin is a very important medication, which is one of the recommended treatment for PID, and this is a recommendation by the Royal College as well as by the CDC. It can be given as 900 milligrams 3 times a day, plus gentamicin 2 milligrams per kg, a body weight as a loading dose, followed by 1.5 milligrams per kg 3 times a day. A single dose of 7 milligrams per kg may also be used, followed by oral clindamycin 450 milligrams 4 times a day, or oral doxycycline 100 milligrams BD, plus oral metronidazole 400 milligrams BD to complete 14 days of treatment. Now, clindamycin is widely available in Pakistan. It's a very important and very effective treatment choice as an inpatient, as well as follow-up treatment for women with pelvic inflammatory disease. Next. Now, those patients who are not responding to antibiotic alone may be considered for operative treatment, and the first line would be a diagnostic laparoscopy, which can be done to confirm the diagnosis of the disease. And certain procedures can be done laparoscopically, such as dividing adhesions or draining pelvic abscesses. However, in those patients who are not fit to undergo laparoscopy, they can be offered ultrasound-guided aspiration of pelvic fluid collections, which of course are less invasive, and they may be equally effective as laparoscopy. Laparotomy may be considered for those who have clinically severe disease with pelvic abscesses or pelvic tubo-ovarian abscesses, and they are not responding to antibiotics alone. They have to be managed sometimes in collaboration with general surgeons, because there may be an extension of infection to involve other pelvic organs, for example, the appendix, or maybe there may be an extension to involve the gut. Next. So a follow-up is very important. The patient needs to be reviewed at 72 hours with moderate to severe symptoms or signs, and if they are not improving, this needs to be further assessment, needs a further assessment with more investigations, parenteral therapy, and maybe a candidate for surgical intervention. So once you start the treatment for a woman suspected to have pelvic inflammatory disease, she needs to be reviewed 72 hours after the treatment has been started to see how things are moving. If things are improving, you can even switch from parenteral to oral therapy to complete 14 days. And if treatment is not improving her clinical condition, then she needs to be further investigated. For example, she may need a CT scan or MRI of the pelvis, and she can be then considered for a surgical intervention. Next, please. Now, the partner notification and treatment of sexual partners. This is a very important component to complete the treatment for PID. As we know that chlamydia trachomatis and Neisseria gonorrhea, which are two very important causative organisms for PID, have a sexual transmission, and this is done through unsafe sexual practices. Therefore, when we have a woman who presents with features suggestive of PID, it's very important to trace and treat the partners, the sexual partners. And they should be, and this is all done with a lot of confidentiality, and it is done through the genitourinary medicine clinics, which can actually contact and trace the sexual partners, provide them with health advice, screening for gonorrhea and chlamydia and other sexually transmitted infections such as HIV. And then they can be offered treatment, and unless the treatment has been completed, They should be sexual abstinence, or they should be use of safe sexual practices. The treatment that is usually offered to the male partners, again, is doxycycline, 100 milligrams BD for 1 week. And they have to be on a follow-up till they have been completely treated, clinically also, and of course provided with health education till they are back to their normal sexual practice. Next. So to summarize, pelvic inflammatory disease, it is very important to make an early identification of the condition. As I said, that treating this condition early is very important because we do not have any definitive diagnostic criteria for this condition. And if treatment is delayed, it can lead to serious long-term sequelae such as chronic pelvic pain, infertility, ectopic pregnancy. Prompt empirical treatment, that is, you should start with broad-spectrum antibiotics depending upon the clinical presentation, which can be either oral treatment or it can be parenteral treatment followed up with the clinical recovery. Very important to provide appropriate counseling, which is in terms of their sexual behavior, safe sexual practices, contact tracing, treatment, and a complete follow-up of the partner till they go back to their normal sexual activity. So partner notification and treatment is very important to complete the loop of pelvic inflammatory disease. Next, please. So thank you very much for your patient listening. And